Hello, everyone. Welcome. My name's Stuart Ekberg. I'm speaking to you today from Queensland University of Technology in Brisbane, Australia. I'd like to acknowledge the Turrbal people, the traditional owners of the land on which we meet. I'm speaking to you from the Kelvin Grove campus of QUT. Not very far from my office is a meeting ground of the Turrbal. So I'm glad to continue that long tradition associated with this land of meeting and sharing information with you today. I'm also very honoured and privileged to follow Claire, Ange and Penny's presentations because many of the things that I'm going to talk about today pick up on key and important themes that they've already highlighted for us. Today I'm going to talk to you about a rapid review that's to inform a national action plan for paediatric palliative care in Australia. It follows from Palliative Care Australia being awarded more than $3 million in funding to deliver a national paediatric palliative care plan project in collaboration with Paediatric Palliative Care Australia in New Zealand, also known as PATCANS. The project was delivered, the rapid review was delivered here at QUT, and I want to acknowledge the large QUT project team that contributed to that. But I also want to acknowledge the Palliative Care Australia and PATCAN steering committee, who provided significant input at a variety of points through the rapid review process. As noted by Ange in her presentation, paediatric palliative care aims to improve the quality of life of children with life-limiting conditions and their families from diagnosis, and this includes but is not limited to end-of-life care. In 2016, almost 25,000 Australian children were estimated to be living with life-limiting conditions, and the care of these children can be complex due to their physiological resilience, the uncertain trajectory of the illnesses that they have, the role of parents and guardians as decision makers, and the ongoing development of a child physically, emotionally, cognitively, socially, and spiritually. In 2014, the World Health Assembly passed a resolution stating that palliative care needs to be provided across the lifespan, including for children, and that it's a moral responsibility of healthcare systems to do so. In response to the complex needs of children with life-limiting conditions, many countries have been developing specialist paediatric palliative care services, including Australia. And as Anne showed, there are now specialist services in many Australian states and territories, although the pace of development has been slower than in other similar countries, such as the United Kingdom. All this work that's occurred over recent decades affords us an opportunity to now synthesize existing understandings of effective paediatric palliative care to inform future policy and practice. And that's precisely what I'm going to do today. So in our work, in our rapid review, we were guided by a series of key questions that were set for us by the steering committee. And I'm going to address many of these key questions in my presentation today. We use rapid review methods which effectively synthesize large bodies of knowledge to inform policy making. Each source that we considered was screened by a single reviewer in a piece of software known as Confidence, with a second reviewer consulted when necessary. Each source was screened by a title and where it was available an abstract, and if necessary, we also looked at the entire full text to determine whether it should be in the review. We didn't use a quality appraisal tool because of the diversity of the literature that we were synthesizing, but we created a customized information extraction tool. Again, a single reviewer in Confidence used this tool. We then used thematic synthesis to bring together all of the information that we identified. Our literature search was conducted in late 2020. We were screening 2,228 sources, of which ultimately we included 369 in the review. So for those of you that do systematic and rapid reviews, you'll appreciate that's a considerable number. It gives us a large amount of information to consider in relation to paediatric palliative care moving forward. The synthesis of this information contained in the included literature sources identified many sources that were relevant to some of the key questions we were asking and relatively fewer sources relating to other areas. No unique literature sources were identified in relation to disseminating information that weren't contained in relation to other key questions. So I won't consider that further today, but I will consider each of these improvement areas on the screen. Our review also identified 4 key policymaking documents that have particular relevance to the Australian context. And each finding that we made through our synthesis, we compared against these 4 key documents to ensure their compatibility with key policymaking organisations. So the first key topic that I want to consider relates to improving the quality of specialist paediatric palliative care and indeed paediatric palliative care more generally. First, the literature shows that patient and family-centred care is promoted as a way of improving the quality of paediatric palliative care, including by key policy-making organisations, something that resounds very strongly with some of the key points that Claire was making earlier. Although there's some uncertainty in the literature about the extent to which patient and family-centred care is currently being achieved, practices such as ensuring continuity of care by a trusted clinician is known to enhance this type of care. A multidisciplinary approach is also known to improve quality, and this is advocated for by key policy-making organisations. This multidisciplinarity should extend beyond specialist palliative care to include other acute care specialties where children receive palliative care, such as in neonatal intensive care. Multidisciplinarity should also encompass community healthcare services, including but not limited to community palliative care. One strategy for facilitating this type of multidisciplinary care across a range of different care settings and services is where specialist paediatric palliative care delivers support through a pop-up model that Ange was describing before. This can help community-based services, for example, to care for families at a time when they need it in a location of their choosing. Finally, setting benchmarks through documents such as guidelines, frameworks and policies is another way to improve quality. We already have some of those documents in Australia, and in the future we might look to initiatives and methodologies used in other countries to further develop these. Early integration of paediatric palliative care, so it's delivered alongside care with curative intent, is known to improve access, and this is also recommended by key policymaking organisations. The most common strategy for early referral or early integration is an adoption of one or more triggers for referral to specialist palliative care, such as those in the Paediatric Palliative Care Screening Scale. Many literature sources highlight the importance of improving access by providing paediatric palliative care in a variety of settings, and key policymaking organisations recommend this. As we've seen in Ange's presentation, a population dispersed across vast geographical space creates challenges for ensuring equitable access to paediatric palliative care. Support for families living in regional, rural and remote parts of the country can be improved through strategies such as the pop-up model that was described by Penny and Ange, and through practices such as telehealth. A number of literature sources emphasise the specific needs of culturally and linguistically diverse populations, and key policymaking organisations also address this. In Australia, policymaking organisations highlight the specific needs of Aboriginal and Torres Strait Islander populations. As is probably well known to audiences in this session, advanced care planning is a process where there are discussions between family and healthcare providers about preferences for care, treatments and goals in the context of a patient's current and anticipated future health. Advanced care planning is recommended by all key policymaking organisations, but the evidence in our rapid review suggests that many children who would benefit from advanced care planning are either not receiving this at all or are receiving it very late in their illness trajectory when its impact may be limited. What the literature reveals is that at the level of healthcare systems, advanced care planning can be improved by early integration of specialist paediatric palliative care, a point that we already considered on the previous slide. The synthesis of literature sources highlights that advanced care planning can also be improved through patient and family-focused interventions. For example, research conducted in Victoria suggests improvements to advanced care planning are made through the use of resources that have been written specifically for parents and carers. Interventions should also be targeted and adaptable to the needs of particular groups, such as adolescents and young adults, and culturally and linguistically diverse populations. In addition to patient or family-focused intervention, clinician training is important for improving advanced care planning, and I'll consider some principles relating to training more generally now. Although 133 literature sources were identified in our rapid review in relation to improving skills and knowledge, we found that there were some important limitations to this literature. First, most literature focuses on improving the skills of clinicians, with far less literature considering ways to improve the skills of patients and families. Second, many sources recommend training in specific areas, but few of these sources systematically sought to determine training priorities, for example, in a country like Australia. That being said, Palliative Care Australia has suggested some priority areas for training, although the findings of our review would suggest that it would be worth a more thorough attempt of trying to determine training priorities. The third limitation is there's a lack of robust evidence in the literature at present around optimal education approaches in this particular setting. What we do have across the included studies for this topic are calls for a foundational level of competence in paediatric palliative care across a range of specialties in paediatrics, in recognition that these clinicians are likely to encounter instances where a palliative approach to care will be appropriate. Developing foundational competencies are recommended by several key policy-making organisations. What is often suggested in the literature is that a hierarchy of skills level may guide investment in training. So for instance, foundational competencies could be required for undergraduate students and those qualified to work in paediatric settings. Beyond this, general palliative care training could be provided to those more frequently involved in caring for children with life-limiting conditions. And at the highest level, specialist training could be required for those whose core activity is caring for children with life-limiting conditions. A recent call was made in the literature to develop centralised repositories of educational resources and curricula that suit the different contexts in which paediatric palliative care is provided. And indeed, that example that example of videos that Penny and Ange were referring to in their presentation would be an example of a kind of centralised repository of resources that is being called for in the literature now. To achieve these repositories, there may be scope to extend existing international initiatives such as the Education in Palliative and End-of-Life Care, EPEC Paediatrics Initiative. And there are also resources available in Australia through that Quokka initiative that was just described by Ange and Penny. A common theme identified across the literature was the need to enhance routine data collection by developing and implementing quality indicators that are relevant to the specific needs and characteristics of paediatric palliative care. Although some key policy-making organisations recommend this, we were unable to identify any quality indicators that were developed or adapted for use in Australia. Beyond quality indicators, some of the literature included in our review has identified priorities for research in paediatric palliative care, although we couldn't identify any work that specifically identifies research priorities for Australia. There are calls in the literature to include key stakeholders across the research project, including child patients, their well siblings, and other family members. And we've already heard in today's panel session how well siblings are often an overlooked part of the picture in paediatric palliative care. Including diverse stakeholders would help ensure that research meets specific needs related to palliative care, paediatric palliative care in Australia. The focus in our review on information about improving collaboration was restricted to collaboration across jurisdictions. So for instance, in Australia, that would be collaborations across federal, state and territory governments. Each of these have a role in developing funding and providing paediatric palliative care. Service development guidelines produced by Palliative Care Australia advocate planning across these jurisdictions to ensure that all children with life-limiting conditions and their families have access to at least one specialist paediatric palliative care service, even if they live in a state or territory that does not have such a service. Overall, very little information was identified to inform improved collaboration across jurisdictions. The QACA initiative that was described earlier is a great example of national collaboration and where we might go what we might build off of in the future. Given the scanned information in this area, there is substantial scope for further work. Improving awareness of palliative care in the community is likely to contribute to enhanced quality of care. We know that people are more likely to use such care when they understand that it's focused on things like alleviating symptoms and improving quality of life. But there's very little work that we could identify in this area. There is some evidence to promote the use of death literacy within schools and working with communication specialists to design public awareness campaigns. But again, like improving collaboration, there really is scope for substantial work in this area into the future. So to conclude, paediatric palliative care has rapidly developed over recent decades, both in Australia, but also internationally. Alongside policy and service development, there's a substantial body of research evidence that's now available for us to use to inform further developments in policy and practice. The major findings of our rapid review facilitate future development of policy and practice by systematically identifying and synthesising information with relevance to paediatric palliative care in Australia. This review has identified many literature sources that provide information about improving paediatric palliative care, with key priorities listed on this slide. Among these, it's clear from the literature that we should be promoting patient and family-centred care, a multidisciplinary approach to care, early integration of specialist paediatric palliative care, provision of care in a variety of settings, use of advanced care planning, developing competence in palliative care across the paediatrics workforce, identifying priorities for skills development and knowledge, and routine use of quality indicators to inform continuous improvement. There are strengths and limitations associated with the broad focus that we've taken in this rapid review. A key limitation that I don't want to hide from is lack of detailed analysis of how to accomplish the many initiatives that I have glossed over today. However, often the literature that we have synthesised has included detailed information, often from review articles, which considers how you might do the sorts of things that we've described in detail. Although the review was broad, an absence of literature in certain areas, such as about Aboriginal and Torres Strait Islander children, means significant gaps in knowledge remain. A key strength is the broad focus of this review and bringing together information with specific focus on the Australian context. The results of this review provide action-oriented information to target investment over the coming decades. The literature review that we produced posed questions that formed a basis for a discussion paper where Palliative Care Australia consulted with a range of stakeholders. The next step for Palliative Care Australia is to develop a thematic report from these consultations and develop a draft national action plan for further consultation. This is due for completion in 2022. Anyone who is interested in hearing more about that could email the address on the screen, and a copy of the full report of our rapid review is available via the website listed on this slide. Thank you for listening today, and I look forward to your questions and comments.